Welcome to Interdisciplinary Case Miles, a podcast where real runner stories meet clinical expertise. We discuss real cases that are anything from weekend warriors all the way to elite athletes, while using our evidence-informed approach.
I'm Dr. Sara Raiser, a running medicine physician focusing on helping runners prevent and recover from running-related injuries while optimizing health and performance.
I'm Kelsey Pontius, a sports dietitian helping runners to fuel smarter, recover better, and help avoid the risk of injury so that they can meet their goals.
And I'm Dr. Mihevc Edwards. I'm a physical therapist and orthopedic specialist, and I've been treating for runners for over 15 years. And what I do is help them get back stronger and better. Each episode that we are doing is dissecting a real clinical case from a runner.
We're breaking it down from every angle: injuries, biomechanics, training, hormones, mindset, and more.
It's really the interdisciplinary approach that we wish every runner had access to.
So whether you're a clinician, a coach, or a runner yourself, you'll walk away with real-world strategies, expert interdisciplinary insights, and maybe even a few aha moments.
This is Interdisciplinary Case Miles.
Real runners, real problems, real solutions.
And this is available anywhere you get your podcast. Subscribe now and join us case by case, stride by stride. Welcome to our very first episode of Interdisciplinary Case Miles. And that is a mouthful, so I'm really glad I got it right on the first time. I'm Dr. Mihevc Edwards, physical therapist, and we have Kelsey Pontius, sports dietitian, and Sara Raiser, running medicine physician here. And the three of us are going to break down cases, difficult cases from runners all over the country. Hi, guys. I'm so happy we're here.
Hi, you too. I'm so happy that we're all here and we get to record us working together, finally.
Yeah, we've been doing this for quite some time now, a few years actually, where we help each other out, even though I'm in Atlanta, Kelsey, you're in Colorado, and Sara is in Virginia. And so we often find ourselves on the phone with each other, talking through cases or sending our patients to talk with one of us or the other one. And this is really cool that we're able to do this. So maybe, Sara, you can kind of tell everybody where we got this idea from. So how did this even start and how did we end up on a podcast?
So the type of work that I do with runners, I really depend on my colleagues to collaborate with me. I need dietitians, I need physical therapists, sports psychologists. I can't do this by myself to get the best outcomes with my runners. So ultimately, the way that I manage my clinics really requires a lot of different hands on deck. It requires a village. And so, like Kate said, we have these conversations all the time. I really enjoy when we get to share patients in the same state, which is not quite the case these days. But I think there's so much value in being able to collaborate and give our runners the best that we can. So ultimately, what we want to do is talk about a case, but kind of the different perspectives that we're all going to come from to be able to improve runners in terms of performance and their mechanics and their nutrition and get them back out there doing what they want to do.
That's right. And we did this actually, I don't know, was it a month ago or so? And afterwards, the three of us had a really good time and we got really good feedback. And it was for a Zoom call for a bunch of different physicians. And then I wouldn't say that I bullied you guys, but I definitely gave you a strong push in this direction. And you agreed.
Well, I'm pretty sure we had about an hour conversation after that Zoom call ended at like 9:45 at night. So I think we're all passionate about this topic for sure.
Totally. Hi, everybody. I am super excited to announce that we officially have our first sponsor for our podcast. And Sara, Kelsey, and I are super excited because we haven't even released our podcast. So this is somebody who really believes in what we're doing. So this is Lever Movement Systems. And I'm also excited, which I've said 3 times already, but because I use this with my patients a lot. So this system is a body weight system where we can offload the body if somebody has a tendinopathy or a bone stress injury, or they're coming back to running postpartum. So there are a lot of different ways that we can use this system and that we use it in our clinic. And I really want you guys, if you've never checked them out before, I would love for you to check them out on levermovement.com because they are believing in us and they're allowing us to bring these cases to you. And so because they're believing in us and allowing us to do what we love, I would love for you to support them. So I'm really glad that we're doing this. And I guess the thing we should do is jump in and start our first case. How does that sound to you guys?
Sounds good.
I'm excited.
Yeah, me too.
All right. So, give you one of our classic cases here. So I've got a 32-year-old female professional marathoner, has a proximal hamstring tendinopathy. So if you know tendinitis versus tendinopathy is more chronic changes that happen to a tendon over time. Tendinitis is usually a little easier to kick than this tendinopathy business. So this is a disorganized tendon that can be aggravating and keep people from getting back to activity. So she's had pain for over 6 months and interestingly has had 3 months of physical therapy, but continues to have pain, and this is really interfering with her running training. So, oftentimes I don't see these patients first. This is a very common patient that will end up in the physical therapy office first. And so, Kate, I want to turn things over to you. So she's come in, she's already seen another physical therapist, and she's saying, hey, things just aren't getting better. What do I do?
Sure. And so with this kind of case, it's typically what we see is people who've been to a bunch of different people and then come in and they just feel frustrated because they don't know what else to do. And so if someone's been in PT for 3 months or longer and they're not seeing changes and they're not getting what they need, unfortunately. So with this kind of person, I would start with my evaluation, which would ask questions like, have you had your pelvic floor checked? And I would ask them, since it's a female, have you ever been pregnant? And if you have been pregnant, what was your birth like? And have you had any issues with that? I would ask about, has anyone even talked about that kind of pelvic floor or lumbar, lower back portion? I would ask about what types of exercises they were doing. Were they doing plyometrics? What was their return to run look like? Or did they ever stop running? Are they doing any blood flow restriction training? Are they doing eccentric training? Did they start sprinting early on or not? So where are they kind of in that physical therapy spectrum? I'm going to ask about running shoes and training. And I am going to ask, have you worked with a sports dietitian? Are you working with a sports psychologist if that's something that I feel like they need? Because it's a female athlete, 32, I'll still ask about menstrual cycle. We'll talk about hormones, all of those kinds of things. So there's so many different pieces of this picture that we really need to understand. From the biomechanics, we're going to watch them run, watch how their foot lands, look at their functional movement patterns, all the way to when did this happen? And did this happen in a stressful part of your life? Were you moving? Were you switching jobs? Did something else happen? Because we know that stress impacts our injury as well. So we're going to kind of go through that entire spectrum. And this is definitely a person that I will pull Sara in on and say like, hey, what have you seen? Or if you haven't seen this person, I might send them for imaging, whether it's ultrasound to look at the quality of the tendon or other kind of imaging depending on what else is happening. And I'll definitely pull Kelsey in because I'll say, hey, this person is injured and has been injured for a long time. What are the nutritional needs that they have?
You know, oftentimes after a physical therapist has seen a patient, sometimes they'll, even if they've gotten to the right person who knows how to treat this, sometimes they'll end up back in my office where Kate just says, hey, want to make sure we're treating the right thing. Is there anything else that we should be doing? Do you want to offer intervention? So a lot of the things that I do are very similar to what Kate is doing. So a very holistic workup in terms of, hey, why is this person injured to begin with, regardless of what the injury is? And, interestingly, I had someone recently who had this type of injury, but she had a partial tear because she went into a split. And it had nothing to do with her going running, right? So sometimes knowing why it happened is really important because I'm thinking about different things from a biomechanical standpoint. And so when she heard a pop and we're worried more about a tear, so a little bit of a different mechanism than just a disorganized tendon. And just to clarify, proximal hamstring tendon is going to be right at that sit bone or your ischial tuberosity. So really, truly a pain in the butt. And so, I'm looking at kind of their holistic picture in terms of why are they injured? Are they making making major training errors? Is there anything that's going on that makes it clear that this is what's causing them to be injured? And then are we treating the right thing? So is this obturator internus syndrome, right? So is this something more pelvic floor like Kate mentioned? Is there something going on within the hip joint, which is pretty common with tendon injuries around a joint? And so oftentimes my job is to rule out all those other things and really do a thorough workup, which might involve some advanced imaging. I'm certainly going to be looking at biomechanics as well and some patterns, but in a little bit less depth than Kate might. Might get someone on the treadmill to take a peek at things from that standpoint, but oftentimes just having a second provider talk to a patient, you get different answers and you get different perspectives. And again, I think that's a big value in having multiple providers on the team like this. And I will often have a conversation that if someone has bone stress injury or they've got a chronic tendinopathy or something they just can't kick, is there something going on from a nutritional standpoint? So I may order some labs, but I will definitely send them on to a dietitian who frequently is Kelsey.
Yeah, you're so good at planting a nutrition seed, I feel like, in the patients that you've sent me. So with something like this, I would also be looking to see if sometimes it helps me to see if there's any other nutritional risk factors. So we know they have a non-healing injury, but some of the things that help me identify is nutrition holding them back, as if they have other risk factors going on at the same time. So I'm also asking them about hormones because it's a female athlete. If it's someone that gets a naturally occurring cycle, are they getting their cycle? Are they on contraceptives? And maybe they think they are, but it's to a degree somewhat masked because they're getting one precipitated by a contraceptive. What do those labs look like, especially the nutrition related ones? Are they able to sleep? A big symptom that I see in runners and athletes in general that aren't fueling enough is disrupted sleep patterns, whether it's issues falling asleep, staying asleep. When that alarm goes off an hour before, or that you wake up an hour before your alarm, so frustrating. Changes to their mental health. A lot of times, if it's a mental health issue like anxiety or trouble focusing that they didn't necessarily always struggle with, to me, that kind of gives a red flag for nutrition. So I'm asking a lot of these different questions. And then even if they don't have any of these risk factors, I think a really important thing to understand as an athlete that has a healing injury is that I almost explain it that you have to be in a caloric surplus so that new tissues can lay down. And so that is really difficult for athletes to wrap their head around, because oftentimes in this stage of injury, we are not, I say we because we're all athletes and active people, we are not moving like we want to. We're not training at the capacity that we want to. And so sometimes there's this cognitive dissonance of, okay, I'm not training how I want to, so why should I be eating like I'm training at full capacity? And it really does take that extra nutritional care because your body's really trying to build you new structures.
It's funny because, we think about trying to heal something, but I think from that logical standpoint, it's hard for us to remember that, oh yeah, we need that extra energy for this thing to heal. And I remember, Kelsey, I was listening to a podcast very shortly after we met, a podcast that you had done with someone talking about nutrition. And you had mentioned that resting metabolic rate can go up 20% when someone is injured. And that was just mind blowing to me. And I counsel folks on this stuff all the time. So it was really cool to hear some of those numbers and understanding that, yeah, this is a big deal. And, I've occasionally had folks that I've referred to a dietitian, and it turns out they're eating 1,600 calories a day, right? So not even enough to sustain someone who's not active. And so having some bigger conversations about that can be helpful. And it's funny, actually, when I just said calories out loud, I realized how infrequently I talk about calories when I talk about nutrition. So it sounded funny coming out of my mouth, but I think sometimes for folks who have looked at those numbers or looked at their ingredients on the back of a cereal box, that's the number that's always on there. Like, this is what we're supposed to be consuming on a daily basis.
Yeah, numbers can be they can be helpful, hurtful, or kind of neutral, right? And so for some of the athletes I work with, it can kind of put into perspective if they are, literate with how many calories certain foods have, and just like the perspective of it all.
Yeah, I think that's really important. And I think when it comes to injuries, nutrition is often one of those things people push aside and don't really think about because they're so focused on the physical piece of what's happening. Something that I kind of want to jump into a little bit further with this case is kind of get into a little bit of the nitty gritty because I think people are really going to want to know, like if someone listens to this and says, I have a proximal hamstring injury, what should I do? Or what am I missing? Or what should I be looking at? I think we can go into that a little bit more. And Kelsey and I have had a lot of conversation around proximal hamstring injuries and kind of what maybe might be missing if something's not improving. And one of the first things I ask people are what we talked about, Sarah, in the beginning is, are we treating the right thing? So we mentioned a lot of different things, but obturator internist actually does refer to the proximal hamstring. So if people come into the office and they have like butt pain when sitting, it may or may not be hamstring. It might be pelvic floor and it might be lumbar spine. So it might be coming from like what I would call like discogenic pain or something to do with the lumbar spine, or it might be neural. So it might be that that nerve is not gliding appropriately and it's causing trigger points all in that hamstring. So it feels like a hamstring. So if you're doing a hamstring stretch and you don't really feel it, but then you flex your foot and then you feel it, or you tuck your chin in and then you feel it, then it's going to be more than just that hamstring tissue. So I think it's important to kind of look at all that. And like you mentioned, the hip. So labral tears can sometimes, depending on which portion of the labrum is impacted, might end up in the back of the thigh as pain. Same with SI joint or other things. So there's so many things. And when you're with a provider, just make sure that they're not assuming it's a proximal hamstring and that they've actually ruled out all of these other things. And sometimes these things come together. So it might be a proximal hamstring, but and so it's getting better for the most part, but it's still hanging on because we haven't addressed all those other things in the pelvis or the pelvic floor or the neural tension. So making sure that we're addressing all those in conjunction with that hamstring if it is an actual hamstring injury. And then the other piece that we've talked about, both of us or all three of us, is that when it comes to a chronic tendinopathy, we have to treat it as such. So we have to do those eccentric exercises. And with a hamstring, you can't just do hamstring curls. You have to do hip thrusts. You have to do bridges. You have to do RDLs. There are a whole bunch of different things. You want to do things in multiple planes. So you don't want to just do that one area. You want to do long lever, you want to do short lever, and you want to do it from the knee and the hip when you're doing exercises. So I think it's important too to know that you have to mix it up in that way. And we have to stress that hamstring tendon early. We have to run fast early. And that sounds very scary. And you're shaking your head because you've been there, right, Kelsey?
Yeah, yeah, it's the last thing that you want to do because your brain doesn't want you to either.
Yeah, and that feeling is like, wait a minute, what do you want me to do? You're actually telling me to run on this? It hurts. Well, eccentric exercise hurts, unfortunately, but we still have to do it and we're not going to do full range if it's too painful. We're going to start with partial range and build our way up. Okay, but same thing with sprinting. I'm not going to tell someone to go sprint 800 meters if they've got a new hamstring injury, but I might tell them to sprint 10 yards just to get the right things going. So I think it's important to talk about that too, because as physical therapists, and Sarah, I don't know if this is true with you in your world too, is I think that sometimes we hold people back too much and we don't actually let them challenge the tissue enough so that they can heal appropriately.
Well, and I think here too, it's really important that you're looking at your provider's experience. So when I'm sending someone to a physical therapist, I want to make sure that they know how to challenge the tissue in a safe way.
Yeah.
So being able to trust your provider and, working together on a regular basis, talking to them on the phone, is really important from my perspective because I want to make sure that we have that open communication. And you're totally right. There are things that do need to hurt. And I talk to my patients about that. The eccentric strengthening is going to hurt, but there needs to be a certain, number one, communication. So I want them to feel comfortable with their physical therapist and be able to tell them when things hurt. If they have excessive soreness afterwards, there's some level of that that's okay, but it really shouldn't be going through the roof and they can't do anything for several days. It needs to be a manageable level of soreness so they can continue doing their physical therapy. And I tell them, if your pain goes through the roof and you can't keep doing things, I want to know about it. Reach out to me, send me a message, come back and see me, because these are important things to address as we're going down the road. I don't want to know about it 6 weeks later. So having that communication, I think, is so important between our collaborating providers, between the patient and each provider. But I totally agree. I mean, I've had several of these conversations just last week.
Yeah. And I think that the pain scale, like using that, people are funny about the pain scale and they're like, what do you mean 10 or 8 or 5 or whatever it is? But I will say that I often tell people, like, you have a baseline, okay? And whatever that baseline is, say it's 3 out of 10 right now, pain. If you exercise with a tendinopathy, now this is not all injuries, I want to be clear, with a tendinopathy, if you exercise and your pain goes up to a 5, maybe even a 6 during exercise, but then drops back down to a 3 within 24 hours, you're good to go. Like, so you have to be able to meet baseline in 24 hours. That is the key. So it's okay that it spikes, because that's the stress that the tissue needs, but it's not okay if it lasts past that 24 hours. And I think that's kind of what you were saying, Sarah. So I like to say that to my people. And I like them to stay, like, if they are going to do something that stresses the tissue, I like them to stay their max being like 5, maybe 6, depending on who they are. And as long as it's coming back down to baseline.
Well, and I like that you're mentioning the type of injury, right? So you want to make sure you have a tendinopathy and that's what you're dealing with. Because if we're dealing with something different, or if we're dealing with a bone stress injury, not okay. Pain is
No.
never to spike. And if we're dealing with something joint, we may also address it differently. So this is where it's very important that you're getting an appropriate diagnosis. A couple of things you mentioned earlier, Kate, in terms of making sure we have the right diagnosis. Oftentimes, part of my role is doing things like diagnostic injections, putting a little bit of anesthetic somewhere, seeing if that takes away pain. So kind of the hunt for the pain generator. And usually I will start with the joint. If someone has just not gotten better with an injury, I want to make sure the joint is clear. So I will typically start with a joint injection. If we numb up the joint, does all the pain go away or do things kind of stick around? Our referral patterns are super interesting. Sometimes tendon pain can be a reflection of joint pain. So it's really helpful to have some of that kind of stepwise diagnostics. Steroid injections, those types of things, maybe in the right scenario, usually in a elite marathoner. I'm not doing a steroid injection. We've got some other options we can consider from a joint perspective. And even same thing for the tendon. Usually we're doing more regenerative type techniques where we're trying to stimulate some healing to happen in that area. But the thing to remember is any of those procedural techniques, minus just the diagnostic injection, are going to require some level of downtime. So we have to plan for these types of things. So if I'm talking to someone about something like platelet-rich plasma or needle tenotomy where it pokes some holes in the tendon to help stimulate some healing, those are going to require a period of downtime. And so we're not going to do that in the middle of the season if someone's continuing to compete. Things like shockwave therapy, we can do mid-season. So we do have a couple of tools that we can do to stimulate some healing. But ultimately, all these things, we need very strategic planning. Again, why it's helpful to have everyone on the same page, including starting to have your coach and athletic trainer who else is engaged in the training and schedule also weighing in to help with that processing.
That's right. And I saw you, Kelsey. You were about to say something and you were, I saw that face.
No, just as someone that has had a pesky injury, this pesky injury, I think also the important thing is the mental health component of an athlete that's dealt with this and was doing the best they could with the resources they had for 3 months, because in their mind, they probably did all of if they're an elite marathon, they did everything the last PT or what the other rehab plan did to 100%. So that's frustrating. You definitely lose steam over time of doing all of these tedious things. We named so many different areas between nerve flosses and strengthening and sprinting and all of these pieces that every day you're like, tomorrow's going to be different. Tomorrow's going to be different. And so, and you have to keep doing it. And so when you go and you see a new provider and they give you oh, it actually wasn't treated as effectively as it could have been, like it feels really discouraging and it feels like you're starting over.
I'm really glad you brought that up, Kelsey, because you're 100% right. And I'm sorry that you felt that. I think we've all felt that, right? That's why we do what we do. That's exactly why we do what we do. But the truth is if you're not, you have to feel confident in your provider. And I do think we have to do research before we see our providers. Know that the person that you're going to see actually understands running, actually gets what that means from a mental standpoint, as well as a biomechanical standpoint and how that's impacting. And then you have to connect with your provider too, right? So if your provider is not listening to you for whatever reason, they're not the right one for you. And I'm not saying that's been your experience or even that that will be anybody's experience, and they can still be frustrated. You could love your provider and be completely frustrated. But Sara made a good point. Like, we have to make sure that our providers have the knowledge to get and do what we need them to do and help us. That's part of, again, why we have this podcast and why we're starting it, is because we think that, not there's so much to learn. I have so much to learn. Each of us has so much to learn. But if we start to pool our knowledge, then we can help each other. Anything
Yeah,
else?
definitely.
Yeah. Anything else you guys want to say about this particular thing? I mean, in terms of hamstring injury for a 32-year-old female, is there anything else you want to make sure that they're looking for or that they might be able to do?
Yeah, so I find kind of going back to the nutritional piece. So sometimes the tendon injuries I find are more challenging to have conversations about nutrition. Bone stress injuries, I think sometimes we kind of understand a little bit more like, oh, we need these certain building blocks, nutrients, and I think maybe it's easier to kind of understand where that problem comes in. Sometimes tendinopathies, it's a little bit of a harder sell. And so I do think that getting some lab work can be helpful, especially if a few things show up and are a little on the low end. What's really interesting from my perspective is when I get lab work, oftentimes if the patient simply pulls up the labs, everything will say normal and they'll write it off and say, oh, everything was fine. And I'll be like, whoa, hold on, we need to talk. Because a lot of what I'm looking at is the range. So, optimal range, especially for an endurance athlete who needs lots of oxygen and to be able to move that in their bloodstream, the requirements are going to be different. And so, there's some increased need for iron, for example, and low hemoglobin is going to have a bigger impact on someone who's an endurance athlete, so anemia. So those types of things, they may not show up as absolutely abnormal on imaging or on their lab results, but we need to have a conversation about what some of those trends are. And so I will often have conversations, especially if we're 6 months into this thing and things aren't getting better. What's going on that's perpetuating this? I'm curious, Kelsey, from your perspective, if you'll maybe give a couple of tips on what you might look for in these folks and kind of what you might address initially. I wonder even if people bring up collagen supplements or anything like that for these chronic tendinopathy injuries.
I think the same thing too, Sara. I think that I always say this, and my injury included, and I've been a professional for over 8 years. All injuries have a nutritional component, and whether nutrition helped cause an injury or if it's a part of the recovery process or both. So I think that's super fair to say that if you are injured, regardless of the injury type, then you need to think about how does nutrition fit into that equation. And so with like a non-healing injury, yes, definitely looking at optimal ranges of labs. The other thing too is looking to specifically how they're fueling around whether they're cross training. Also, big trend that I see is not considering, and Kate and I talked about this with another athlete that we work with together, not over cross training because the body's needing time to heal. And so if we're over cross training, I think that there's something to be said about making peace with the fitness that you're going to lose at that point, and with the goal of getting back into full training sooner. Because that's stealing from the energy we need to heal. With tendon injuries, specifically with like supplements and everything, I am making sure that we cover the grounds of low energy availability, avoiding within day deficits first. Collagen to me is like anywhere between like maybe a 5 or 10% at best, 10% at best. Once we're doing all of those things, then looking into collagen implementation. There is good research to support it. It's best used 30 minutes before you get blood flow to an area, is kind of the information that we have right now. In my experience, myself included, people forget to take their supplements. And so if they're putting all of their eggs in the supplement basket, there's just so many other things we can be doing, not to mention our bodies make our own collagen. Obviously, that production slows down throughout our lifespan, but at 32, we're still making collagen. So making sure that we're meeting those energy availability needs and then hitting the micronutrients too that help support collagen production. In my experience, if we're eating a well-rounded diet and we're consistently eating every 3 to 4 hours, then those micronutrients will take care of themselves. To name a few, they are vitamin C, copper, and zinc. But those are super easy nutrients to get within the diet. It's a lot of protein sources and then vitamin C, fruit, and vegetable. And so if we're eating, 5 or 6 times a day, then and eating in a structure of a balanced diet, then those should be pretty easy to check off.
Awesome. So I think with that, you guys, I have this idea. I didn't tell you beforehand, of course, because this is how it goes, is why don't we leave the episode with one thing from a PT, one thing from a dietitian, and one thing from an MD that whoever's listening to this might take away if they have this long-lasting proximal hamstring injury. What can they go into their provider with next? Or if it's a provider listening to this, what can they look at for their patient that they're having a hard time with? What do you think?
Great.
Cool. Why don't you start, Sara, then you, Kelsey, and I'll finish.
Yeah. So my number one thing is make sure we're treating the right thing. So someone who comes in with a hamstring tendinopathy diagnosis, I'm going to do all the tests in the book to make sure that it's not something else that's going on, or even are there small contributions from other things like the back or the hip joint.
I would say for me, to put your performance hat on when you think about your fueling and let go of trying to stay in shape, let go of trying to maintain the size of your body. That will all work out in the end. Put your hat on of trying to heal and try to eat enough. And that's the number one thing you could be doing to heal an injury.
Awesome. And my thing, if this is a proximal hamstring injury, and we know that that's what it is for sure, or if it's part of the equation, making sure that you're doing your eccentric work in multiple planes, making sure that you're challenging the tendon and the muscle enough and kind of staying within that 24-hour pain cycle that we talked about so that you're getting the stress that you need to that area so that it has time to heal, but then not overdoing it. That would be what I would say. So great. Thanks, guys.
This is great.
Yeah. So everybody,
That was fun.
yeah, it was fun. So everybody, thanks for joining us for our first episode for Interdisciplinary Case Miles. And we are going to try and get you something once a week. We're going to do our best. We're all really busy ladies. So I'm just promising that we're going to do our best. And we are actually getting together this week. Actually, we'll see each other tomorrow or Wednesday morning. So hopefully we'll get to do a few of these in person. But if you have any cases that are difficult and you aren't sure what to do, in our next episode, we'll give you our email address because I forgot it. But we will give it to you and you can send us in cases. But right now we have multiple cases that we're going to go through for our first few episodes, but soon enough, you'll be able to send your own cases in and we'll kind of talk it through. So thanks a lot.